I'd like for everyone to think for a moment about the value of human life. And does one person's life have any more value than another person's life? The current fee-for-service system, healthcare is rationed out based on the patient's ability to pay. I believe it's unethical. This is criminal. 95% of the country is still functioning in the fee-for-service model. I definitely believe everyone should be treated the same.
Everyone should have access to primary care regardless of their ability to pay.
Hi, I'm Dr. Faisel Syed. Thank you for joining me this week for another episode of Fridays with Faisel. I believe that everyone deserves access to quality primary care and should be treated the same regardless of their ability to pay. Today's topic is integrating behavioral health into primary care. I have three guests joining me today. But first, I'd like to introduce Robert Longyear. Hey, Robert.
Hey, Faisel. Good to see you. Good to see you.
You know, Robert, you started as a special guest, and even ended up hosting an entire episode for me when Hamza, my son, got sick. Mm-hmm. I wouldn't be broadcasting live today on all these different platforms if it wasn't for you joining on the Instagram Live with me early on. So thank you. Thank you so much.
Yeah, it's been a great pleasure to do this series with you.
We're also joined today by Dr. Dan McCarter and Dr. Nehal Gheewala. Now, we can have multiple guests at the same time. But the idea of going live was actually originally Dr. Dan's. And Dr. Dan, thank you so much for always pushing me to do more and better.
Absolutely. It's great to be with you here, Faisel, and it's great to see what you're able to do with your outreach.
Oh. And we have Nehal Gheewala. Nehal, you are like a little brother to me. He also happens to be my father's doctor.
It's a pleasure to be here, Faisel. Thank you so much for having me.
When I see you, I see one of the future healthcare leaders for the entire country. I really do.
Thank you. It means a lot.
So let's get started. In many ways, I see improving patient care starts with behavioral health. Usually to see a mental health provider in the fee-for-service world requires a referral from your primary care doctor. And then you have to find someone, you got to make sure they're in network, and then you start running into all the barriers to access. And Robert, if you could just share a little bit about the barriers to access. I mean, this is a topic that we're really passionate about, improving access to care, but especially when you're talking about trying to improve lifestyle or do lifestyle modifications, having access to behavioral health is fundamental.
Yeah, I think one of the core issues in healthcare, which I sometimes struggle to realize that we're still talking about this in this day and age, is just actually having access to healthcare service, having access to primary care. There's plenty of people that just don't have that for cost reasons. It's too expensive for them to see a primary care physician. They don't have insurance, so it becomes too expensive. They're physically located in a rural or area that doesn't have a nearby primary care physician. Or mental health providers for that matter. And there's a lot of other reasons that people don't have access to care. It could be just time. So maybe working two jobs and can't get off work to physically go into a location for primary care. They can't get childcare. So it makes it even more difficult to actually make it into a clinic. And so I think that that's really important. And when we think about behavioral health, there's sort of the behavioral health part of chronic disease that is really important, those lifestyle changes, those behavioral changes, but there's also just behavioral health in terms of mental health conditions. And primary care is very important for that because about 20% of primary care visits are mental health related. So access to primary care is essential to both getting those referrals and to actually getting treated in the primary care setting.
The whole concept of just getting a referral is for behavioral health, especially when you're talking about using behavioral health for motivational interviewing, for chronic disease management. Like let's say if you're for nicotine cessation. If you have a smoker and you're trying to help them with quitting smoking, someone who's trained in motivational interviewing, I mean, I find that the process to get a referral, to get someone, especially a behavioral health person, to help make lifestyle modification is just so unnecessarily, I mean, I just feel like it just causes delays in itself, completely unnecessary.
Yeah, Faisal, I think sort of the state of the art is the embedded behavioral health into primary care. The impact model from the University of Washington, they show great outcomes. You can do it with, you don't have necessarily, you have to have a psychiatrist involved, but the psychiatrist doesn't have to be on site. And they actually show much better outcomes from mental health. And then for these other things, as a PCP, if you've got a patient that wants to stop smoking, when do you need to talk to them? You need to talk to them now. You don't need to talk to them in a month or 2 months, whenever the insurance gets approved and you can get them in there. So I think you're absolutely right about that.
And especially how many times we've seen in the clinic that you need like a same day behavioral health access. I mean, you're trying to make a difference in your patient's life. You got a situation, and then you have to tell them, well, hold on, I got to get a referral. You got to get the referral authorized. You guys find somebody that they can go see. And many times, at least in the primary care world, when we're actually trying to make a difference, I feel I would imagine that that's probably a great source of frustration amongst primary care just in general.
Yeah. Yeah, and Faisal, it definitely is. That's what we've kind of understood coming from sort of the Medicaid space in particular. But the three of you guys are all physicians. You're all primary care physicians. And so what I want to ask you is, in light of the fact that one of the best practices is actually co-locating behavioral health services and integrating it into the primary care setting, if you don't have that as primary care physicians, what is your comfort level in training for dealing with patients with depression, dealing with patients with anxiety, and actually managing that yourselves?
That is an excellent question, excellent point you're touching upon there. We're talking about one of the most complex, most needed, and most undertreated areas of healthcare is mental health. And this is something that actually comes up in a lot of primary care. I mean, there's some data through National Institute of Health that 1 in 4 American adults will suffer some form of mental illness, whether it be depression, sometimes more than one condition every year. So these are things that through frequent follow-ups and frequent visits with their primary care provider should be addressed and should be touched upon. Most primary care providers do feel very comfortable, but there's always a key factor of time, right? And something that we stress in primary care, you must spend time with these people. If you don't spend time with these people, they're not going to get the care that they need. And then giving them a referral to get into primary care, I can tell you out of experience, is that getting them into a psychiatrist's office may take a month, may take more than that. And sometimes you just don't have the luxury of time. In the meantime, you're actually receiving just poor patient outcomes. The patients are suffering. So a lot of this should be front loaded with primary care, spending the time counseling the patient, looking at see if they have any other concomitant conditions besides just one mental condition. Sometimes you can have more than one mental health condition. You have substance abuse disorders, anxiety disorders that can compile on top of that. So spending time with the patient in the beginning and consider starting some medical treatment. At the minimum, at least counseling would be the best first step. In addition to that, sometimes there are social stressors. So that, like you were saying earlier, Robert, social determinants of health are key. They're absolutely key into solving some of these problems. And no referral sometimes will even address that. It's spending the time. And I think that is the rate limiting step here is actually time.
Right.
Equation.
Yeah. And Faisal, we know that fee for service doesn't really let that happen very well, does it?
Yeah, the average doctor is only spending 20 minutes of FaceTime per patient per year in your traditional fee-for-service practice. So it's not only, I feel like most primary care doctors are very comfortable managing depression, anxiety, just like they're comfortable with managing, insulin-dependent diabetes or coronary artery disease or, whatever chronic condition. But if they don't have the time, like Nehal was saying, they'll end up being more likely to refer. It's part of one of the blessings we have in the full risk model is not concerning ourselves with the frequency of having to have these large panels of 2,000 to 3,000 patients. It's one of the luxuries we have with having a couple hundred patients to manage.
Right. Right. And one thing that I'm also curious about from you guys, and maybe I'll ask Dr. Dan, physical health and mental health, they affect each other. If you're depressed, you might be more likely to not care for your hypertension or your diabetes. And being that you might be diabetic and feeling stresses from that, you might end up experiencing depression. How do you manage that? And how do you sort of navigate that in a primary care setting?
Robert, I think you're absolutely right. And I think it's very difficult to say where the mind exists physically, right? I mean, you'll hear people talk about, somebody's a pain in the neck, or that breaks my heart, or that hits me right in the gut. And people have those physical symptoms related to stressors or what's going on in their life. Not to mention the fact we know that physical activity can be the equivalent of taking a dose of antidepressant if we can get people to be physically active. And we don't go home with patients, right? So we see a patient and they go home for, even in our model, they may go home for 4 weeks, and they've got to take care of themselves for that 4 weeks. So I would argue that behavioral health is involved in everything we do, because behaviors affect every other illness. And I think it's really about, I've thought about this, and pretty much all education is about what you can get somebody else to say or do, not what we tell them. So it's got to be more about creating a partnership with the patient than it is about telling them what to do. We have to get their buy-in for the plan, and it's their health is co-produced. It's not, we don't give it to them. They don't take it from us, but we work with them to produce that product. Robert, I've got a question for you, if that's okay.
Yeah.
It seems to me like there's a big shortage of, payment parity. That's a big deal for mental health and for physical health. And I've heard it said that something like only 25% of private psychiatrists are taking referrals, even if they're paid for by insurance. And I know personally, a few years ago, I had a family member wanted to get them to see a psychiatrist, or not a psychiatrist, a psychologist. It was nothing serious. And I called with my good insurance, and they said, "Oh, it'll be 6 weeks." And I said, "Well, can we do it any other way?" And they said, "Well, if you want to pay cash, I can see you Sunday afternoon." And this was like Thursday. So, I think for us all agreeing that we want access to equitable care for everybody, that's not equitable care. And even if you had the insurance, we didn't have access. So we only had access if we wanted to pay out of pocket.
Right. So there's a lot of, first of all, there's a big shortage of mental health providers in the United States. And that's part of the problem is there's just a lot of demand for it, and there's not enough supply. From the provider perspective, and providers are also not geographically located equally across the country or across geographic areas. So you might run into a situation where there's no mental health providers within 45 minutes of home, and so that's why a lot of patients may have access to a primary care provider, and then they'll get their mental health care there. But it puts a lot of stress, and there's not enough time associated for those primary care providers to manage it adequately. And payment is a big driver of why this is a problem. So if there's not payment parity, if it's not covered by insurance, you run into a situation where a smaller subset of the population actually can access mental health services that are very, very expensive, particularly like clinical psychologists. And so there's been a big movement, I should say, in sort of the payment world to try and bring payment parity together, and to start trying to, from the payer perspective, looking at behavioral health and mental health as affecting each other. I know in Medicaid, for example, states previously kind of carved out their managed care plans. They put behavioral health in one side and they put physical health in another organization. And so then they were sort of two separate coordinating entities, and that didn't go very well. And so now there's this push to kind of reintegrate behavioral health into sort of the managed care and the payment side of healthcare. And then one way that organizations have been trying to get around this is to also co-locate a physical mental health provider in a primary care setting. And then they've also been using virtual care and telehealth to do this as well. So if you don't have access to a mental health provider that can come physically into the clinic, sometimes they can use telehealth to come into the clinic and have a visit with the patient while they're sitting there physically or in the home. And that's a huge area of investment and growth as well. So yeah, payment drives a lot of behavior at the provider level. And it also affects how many providers get into the space if they don't have sufficient funding to do that.
For me, I mean, it drives me nuts when patients have to pay 2 copays. If they see a primary care doctor and they see the behavioral health person the same day, they get having to deal with 2 charges. Just find that, for something that challenges so many people, I mean, why give that additional barrier?
Yeah. And that's the beauty of the full risk model, though, is that you get to sit there and say, what does my patient need? What can I afford? And if I do drive benefit for that patient in terms of shared savings, then it's worth the investment. I can make that investment. And I think that's what you three are very fortunate to operate under.
It's every doctor, though. Every doctor wants to make sure that they can fulfill the needs of their patient. It's not, I mean, I bet you that's probably one of the main frustrations in the fee-for-service world, is you're seeing these people and you don't feel that you're actually making a difference.
Mm-hmm. Yeah, I think that's a big contributor for physician burnout. I know you three are big advocates for full risk to try and help physicians actually get back to what matters in medicine and building that patient relationship. And I think that in the fee-for-service world, where you have to see 20 patients a day and you have 15 to 20 minutes for each patient, you don't feel like you're doing any good, and you're just a cog in the machine. You're not getting to practice medicine in the way that you had hoped you'd be able to practice medicine.
No, we invest in our doctors. I mean, with something like I was fortunate in residency to have motivational interviewing training during residency, but in part of our 3-week onboarding process in our world, I mean, we spend an entire day just training the doctors some of the skills with motivational interviewing. That may sound crazy to some people. I think it's so fundamental for people to have that understanding.
At Avenue, we do programs for remote patient monitoring, and so our virtual care clinicians, they're mostly nurses, are trained in motivational interviewing to sit there and try and reinforce positive behaviors for lifestyle change and care plan adherence as well.
Yeah, I think that that integrating behavioral health into primary care is going to first require that culture change.
Yeah.
Like when we're talking about preventing disease or intervening in any kind of disease management, usually we start, there's an element of lifestyle modification that's tied to it. I think that just earlier today, Dr. Dan, we were talking about tying in lifestyle really to all forms of treatment.
Absolutely. I mean, your number needed to treat is, and I'm sorry, I don't have the numbers right in front of me, but the number needed to treat, if somebody walks 2 miles a day, you save more lives than treating high blood pressure. And, if you lose 10 pounds, it's probably equivalent to taking, thousands of dollars worth of diabetic medicine every year. So it's, I guess it's, I've heard it said that, attempting to manage social and behavioral issues at the micro level with pharmaceuticals is just it's going to be a losing battle, and we've got to figure out how to engage with people and work with them to lead healthier lifestyles. But then there are going to be all the social issues that go along with that as well.
Yeah, it's been a losing battle. Chronic illness is the driver of all the costs, when we know that it's often very preventable or manageable if you would address those risk factors. But making those lifestyle changes is like the holy grail of healthcare services, at least the way that I was taught. And so Dr. Gheewala, I'm curious, what do you do to actually try and encourage patients to make that lifestyle change, get them to walk a little bit more or to eat something a little bit different?
And so no matter the ailment, there's this thing that they teach us in medical school, is that 80% of your diagnosis comes from the history, right? I see these guys, everyone's shaking their heads. Anyone watching right now, you'd say, yeah, absolutely. And it's first is listening, finding out what's going on, get the full scoop, find out every little bitty thing, and spending the time with someone and see where they're at, and see what their hesitations are, see what their barriers are, really dig into it, make them make a list for whatever it is. If it's weight loss, if it's maybe, a list of foods that they like to enjoy and they just don't know how to balance that, using weight loss as an example. or if you want to do something like mental health, finding out what are the stressors in your life. Actually sitting down and getting that 80% of the diagnosis is in the history, keeping that in mind, getting that information will lead you to the finish line. And that's what often gets forgotten, is that we need to get back to spending time and listening. And then, like Dr. McCarter was saying, not trying to use medications unnecessarily to treat a social problem, and really get down to the root of it. And like Robert, you were saying earlier, is that in certain areas of the United States, there are these like healthcare deserts, as I call them, where people just don't have access to good healthcare because the nearest doctor is over an hour away. The nearest psychiatrist is 2 or 3 hours away. Leveraging technology for those difficult cases that primary care has been working with and has been trying their hardest with, leveraging technology to say, hey, let's get you to come into the office and we can do a consultation right here with a psychiatrist like telepsych. That has an extra layer. And I think that's where, technology is kind of pivoting healthcare for the better, but we shouldn't forget where we came from. We should still be getting down to that history and physical taking, because that's how you influence an outcome, no matter what it is. If it's behavioral health, if it's cardiac, if it's a respiratory illness, getting down to what is the root cause here.
Right.
I'd like to thank you guys. This is a great discussion. We're running up on time, just flew by, like it's already been over 20 minutes. So I'd like to, if there's any questions or any comments, if we could answer some of the people who are engaging in the chat windows with the different platforms. Maybe answer or engage with a couple people before tying it all up.
Look, it looks like Scott Waters has asked a pretty interesting question here. Do you ever find fear as a good motivator for patients, or is it more of the positive reinforcement that's more effective?
I mean, I think that's a great question. It depends on what the patient's fears are. Again, getting back to what is driving this, because what a fear to me is not necessarily a fear to someone else. So then once you get that, it's all about relating to someone. So once you relate to that human being and you find out what their fears are, then you tie things back into their fears. Because using, let's say, for example, about how hypertension and diabetes could kill someone if they get out of control might not be what motivates Mr. Smith. Mr. Smith might actually be motivated by something else, and it could be something social.
Yeah, I like to think of it, whenever you're addressing anything as a doctor with a patient, first you have to start with the relationship. There's a relationship between the doctor and the patient that is a sacred one. And the doctor and the patient should work together to achieve goals that are beneficial for the patient. So when you have both setting real expectations and working together towards achieving that common goal, the need to use fear, I mean, what is the fear? The fear usually is for the patients. It's a patient's fear of the unknown when it concerns, especially something like hypertension, where 95% of patients have zero symptoms whatsoever. So I don't see the need in using fear. Actually, I think that just in general, it's a terrible way to approach reaching any sort of positive conclusion.
Okay, let's see if there's any other questions here. One thing that I think is really important for us to recognize here is it goes back to access, but so about 67% of adults with a behavioral health disorder do not get behavioral health treatment. So that's a pretty substantial number. What are you doing at ChenMed specifically to actually try and address sort of behavioral health in your patient population at large? Are there any initiatives you're working on? This question comes from Kevin to see if there are actually any things that you guys are doing specifically for, let's say, depression or anxiety in older adults. Faisel, we did a episode on loneliness. So I'm curious if you guys are working on that at all.
Great question, Kevin. The 60% that you're mentioning, I mean, you can also look at the current fee-for-service system. Remember, 95% of healthcare in America is fee-for-service. And with the current fee-for-service system, at least pre-COVID, half of all medical care was delivered in the emergency room setting. Now, you know as well as I do that number was grossly too high. And the same goes with the 60% of people who don't have access to behavioral health. See, there's value-based care, and then there's a full risk value-based care model, and that's the world that we exist in. So in our world, we don't concern ourselves with billing or even with the whole process of referring for behavioral health. You have it integrated in your clinical practice. I use behavioral health not only for things like depression, anxiety, PTSD, bipolar. We use behavioral health for motivational interviewing to help the uncontrolled diabetic, or to get their diabetes under control, or someone who's overweight or obese, setting realistic goals and expectations to get to that healthy weight. So it needs to be integrated within primary care itself.
Yeah, and actually, Robert,
right,
we are
right. And so here's, go ahead.
Well, I was saying that we are working also on a social determinant of health identification program. So patients who have extreme social determinants of health that are actually affecting their outcomes, we're working on identifying them. Simply just identify it and then work on root cause analysis and getting them the help that they need. Because most of the time, actually, I could say all the time, if you improve that social determinant of health, that is the main driver for all poor patient outcomes, whether it's mental health, whether it's cardiac, it could be respiratory, it's access to care. And if we work on these things, that's actually where we find you can motivate the patient the most. And that is the biggest thing that we've been working on as an organization.
Yeah, and that's going up to those causes of both behavioral health conditions and physical health conditions. So I know the first step, I believe you guys might be using the prepare tool, perhaps. The first step is just collecting that data and then figuring out what to do with it as the system continues to prioritize social factors. But I think this all goes back to one last point that I think we should all comment on, which is providing value in healthcare. So what services actually do provide the most value for the outcomes that you're getting? And I think that behavioral health integration has proven in a lot of studies that it's a pretty high value service. Being able to address that is pretty high value. What do you guys think about that? We're trying to do things that actually impact health. And that's the whole purpose of value-based payment. It's not just sort of changing payment and reducing volume. It's also like what can be done to actually influence the outcomes that we're hoping for. And a lot of it, I think 70% of healthcare outcomes are affected by individual behavior or socio and economic factors. So that's 70%. So it's not prescribing the pill. It's those two items.
Yeah, it's improving health. It's a system where the incentive is to improve health. The incentive is to reduce all the waste that we see in healthcare today. And when you're incentivized to improve health and reduce waste, then you focus on things like prevention and early intervention. If you have an unstable patient, God knows, somebody who's been managed inefficiently for decades even, in our world, our average patient is 72 years old. Many times we'll meet people who have, it's not that they're a victim of malpractice, but they're a victim of just being managed inefficiently. You have to stabilize the patient and stabilize the patient as efficiently as possible, and then move on to preventing any unnecessary complications from that.
Yeah, I think you're bringing up a good point about the value-based system, but I think it's important because in the value-based system, the incentives are aligned, good outcomes for the patient, rewards the clinicians financially. But the other thing I would say is the RVU fee-for-service system was built as a sick care system. It's built by doing things, and for us to be effective, you're going to have to turn the system upside down, where primary care is going to provide the leadership. And I think that's what our, obviously I'm a primary care doctor, but I think that's what our patients are going to need to do well. And I know people are frustrated saying that we can't do that, but I wasn't a doctor at the time that DRG started, but I was old enough to remember it. And October 1st, 1983, we went from a cost plus system to a DRG system. So I think we can go to a value-based system. I think it's just a matter of getting the stars aligned and getting the politicians on board with it.
Right.
Wow. Great discussion, guys. Today was a great discussion. We try to keep it to 10 to 15 minutes. I just don't think that's possible. Especially when you get the Dr. Dans of the world and Nehal Gheewalas, and you get Robert Longyear. I mean, this was just great. Thank you so much for just an awesome conversation. I look forward to post-COVID, us getting together and having these, in person.
It's fantastic.
Yep.
Thank you so much.
I do too.
Yeah, thank you. This was great.
Well, to anyone who's joined us, thank you so much for joining us today. I hope that you found it informative. For more information about today's topic, as well as value-based care, please visit chenmed.com/resources. We look forward to seeing you again next week. Please share with your comments any particular topics you'd like for us to discuss. We all believe that healthcare is a right, not a privilege. Thanks.